already for desired effects. She discussed morning sickness and dyspepsia. This subsequently led to her gradual increase in her cannabis consumption to help treat her symptoms. She also had hyperemesis and abdominal pain. She would then repeat the cycle and begin using cannabis, resulting in the same outcomes. During her emergency room visit, she was treated with IV fluids, haloperidol 2.5 milligrams IM, capsaicin cream, and she was discharged to home to continue care there. Following the visit, she has been able to maintain abstinence, and her weight did recover over the next year's time. She's also been able to maintain her employment. Just a quick review, the cannabis activates the CB1 receptor, resulting in inhibition of gastric secretion, lower esophageal sphincter relaxation, altered intestinal mobility, and overall delayed gastric emptying. The next case is based off a 32-year-old male with a 10-year history of cannabis use who is looking to start applying for different jobs. He feared, though, that he would not be able to pass the mandatory drug testing, and he also noted that use has caused issues with his relationship, and he began skipping family events. He did quit 48 hours prior to his appointment, which he discusses how he is having terrible dreams, poor sleep, sweating, diminished appetite, anxiety, irritability, and cravings. He denies that he has any other issues with drug use or tobacco use. He denies any excessive alcohol intake and estimates that he drinks twice yearly socially. We discussed different options, including behavioral management, including cognitive behavioral therapy, which is a well-studied approach focusing on the thoughts, behaviors, and triggers that reinforce substance use. This is readily available in our community, as well as peer support in NA and AA. We also reviewed different medication options, including dronabinol, which would help reduce his general symptoms, gabapentin, which would benefit his anxiety and insomnia, NAC, which would help him with his liver health, naltrexone, potentially benefit cravings, quetiapine, help with his sleep and appetite, mirtazapine, again, help with sleep and appetite, and guanfacine for irritability and sleep. At this point, he chose gabapentin 400 milligrams 3 times a day. He felt like this is something that he would be most comfortable with. We also discussed the possibility of adding MAC 1200 milligrams BID. He did have a negative drug screen at 12 weeks and was able to begin applying for jobs. And that's all I have for you today. Thank you.
Thank you, Gail. So I think next we'll move on to alcohol with Ed, but before we do that, we can take any questions, comments, any discussion related to cannabis. Or we can also bring those up at the end too if people don't have anything yet. I'm not seeing anything right now, so we can just maybe bring those up at the end. Ed, do you want to take it away from here?
Yeah, you bet. Let me try to get my screen share going here. Again, part of the reason we're kind of doing just some case studies today is to just give us a little bit more time to open up the floor for more discussion. So while we're kind of going through these, if anybody does have questions or things they want to drop in the chat, like Will said, please do that. See if I can get it set up here real quick. All right, does that look okay, Will?
That looks great.
Okay, excellent. So yeah, I have a few different sort of clinical application things, but just a quick review sort of about our conversation about alcohol from a few weeks ago. So the agenda that we went through was we talked about alcohol assessment, then we kind of went through the neuroadaptations to chronic alcohol use. We talked a little bit about alcohol withdrawal syndrome and sort of how over the course of time, the more often that you do that, sort of the worse it can get with that kindling effect. And then we talked about some of the medications, you know, specifically for alcohol use disorder, and then more specifically about the Sinclair method and how to like treat patients with that method. And now we'll kind of go over some of the clinical applications related to that. So this this is the chart about the different medications for treatment of alcohol use disorder. And again, when we're treating patients, generally we just say we recommend that if they go through some sort of detox process, that we offer them some sort of medication management after they go through detox. And so this little graph or this little this graph just really is helpful for me. So when you look across the board, all the different medications, again, the naltrexone, acamprosate, and abuse are all FDA approved medications, where the topiramate and the gabapentin are not. We talked about mechanism of action of these different medications, and it's sort of listed there. When it look at reducing heavy drinking, so the naltrexone and the topiramate are primarily the best ones for that. And then all of these medications essentially can be used for relapse prevention for individuals that have stopped drinking and don't want to go back to any alcohol use. The only one with really some maybe minor abuse potential is the gabapentin, so we do want to be mindful of that. Abstinence and treatment, primarily the acamprosate, and then obviously the disulfiram or the antabuse. We don't want patients drinking. Safe in combination with alcohol. This is always important too if patients are having a return to use, but the naltrexone, acamprosate, and topiramate generally are going to be safe with a return. Obviously, don't want to use the antabuse, and then the gabapentin can cause increased sedation with alcohol use. And then again, for pregnancy and breastfeeding, really none of the medications are recommended for alcohol use disorder in that population. So I have about 5 different sort of clinical application questions, and then a little bit more of a specific actual case study, but we'll kind of go through these together. So the first situation is a patient with isolated severe alcohol use disorder. Essentially, they come into the clinic after completing a 7-day inpatient detox program. So again, pretty common to see patients after they've gone through detox. He's expressing significant cravings for alcohol and requesting medication to support his goal of essentially prolonged abstinence. So the question in all of these is, hey, what's the most appropriate sort of first line medication option for this patient? Again, assuming that he's healthy and doesn't have any other contraindications. You don't have to blurt out the answer. I'm going to give it to you here in a second, but I'll give you a minute to think about it. So generally speaking, naltrexone is the first line agent for alcohol relapse prevention. Patients can be initiated on the oral naltrexone, and they can also receive a trial of the Vivitrol. So again, we talked about Sinclair method versus naltrexone on a daily basis. This is just saying, hey, we're just using naltrexone on a daily basis with no return to alcohol. Still a good medication for that. So some of the questions is, hey, why not acamprosate? And again, a good medication, maybe a little bit less desirable due to the dosing schedule where you have to take it 3 times a day, and also due to some of the side effects, mainly just like GI issues with that. Again, disulfiram can be effective in specific patients where they have supervised, really highly motivated individuals. Topiramate, gabapentin, again, both not FDA approved medications, but definitely could be considered as second line options for this individual. All right, here's number 2 for you. Patient maintained on buprenorphine. So history of moderate alcohol use disorder in remission. The last drink was 6 months ago, so this patient has had a period of time use. Recently developing cravings for alcohol and is requesting some sort of pharmacotherapy to maintain the goal of abstinence from alcohol. So again, what is the most appropriate maybe medication for this patient, assuming he's healthy and has no other contraindications? And so again, generally in this patient, would maybe consider starting them on a camprosate. Again, effective alternative to naltrexone and is a reasonable first line choice in patients who again have some sort of contraindication to naltrexone, which primarily would be some sort of like severe allergy, or obviously if they're on buprenorphine or opiates. Again, the naltrexone, we can't use that with the buprenorphine. Antabuse, again, same reason as before, mainly under clinical supervision or supervised individual that's highly motivated. Topiramate, not FDA approved for AUD, so second line. And then gabapentin, again, not FDA approved, second line, but also there is a little bit of a risk for oversedation with the gabapentin and the Suboxone. Again, this doesn't like really worry me in terms of like, hey, when you're initiating somebody on the gabapentin who's on buprenorphine, you may want to be mindful of oversedation. But we have lots of patients that are taking gabapentin and buprenorphine and do fine once they're sort of on it and used to it. But something to be mindful of maybe why I wouldn't use the gabapentin first line in this situation. Okay, so same individual, sort of same story. He initiated on the acamprosate, so we started him on the acamprosate, but then he stopped the medication a week later due to the sort of the GI effects of the medication. And so in this situation, so what would be the next sort of second line option that maybe we would consider for this patient? And again, we sort of talked about this before, but topiramate would be a good option for a patient who's previously failed the first line option. No significant risk of respiratory depression when taken with the buprenorphine. One just caveat on the topiramate. Generally, we got to start it on sort of relatively low dose and sort of titrate that medication up over the course of weeks, and then generally recommend that we titrate it down as patients decide if they're going to discontinue that medication. All right, here's number 3 for you. Patient is maintained on buprenorphine, history of moderate alcohol use disorder with ongoing alcohol use. Last drink was 12 hours ago. And again, requests pharmacotherapy to help reduce the heavy alcohol use, but he's not necessarily interested in full abstinence. And so, what would be the most appropriate medication for this patient? So, again, on buprenorphine, still drinking, but wanting to reduce the heavy alcohol use. And the answer to this one is also the topiramate. So again, when we looked at that chart from before, topiramate is helpful in reducing heavy drinking, and again, does not carry the risks of respiratory depression with taking buprenorphine. Naltrexone would also be helpful, but we can't use it because the patient is on the buprenorphine. Acamprosate is mainly effective for patients who abstain from alcohol for a period of time at treatment initiation. It's a little bit of not exactly sure how long abstinence means. I've had patients started after 24 hours, but generally speaking, a longer period of time to start the acamprosate would be better. And again, gabapentin, we would say that was probably contraindicated because the patient is continuing to use alcohol. They're on the buprenorphine as well. And so that combination, the more sedatives we add to that patient's situation, a little bit more dangerous it gets for them with oversedation with alcohol, gabapentin, and the Suboxone. And then obviously can't use the disulfiram or the antabuse because of the withdrawals that the patient will have from that. All right, number 4 here for you. We have an 18-week pregnant with mild alcohol use disorder. She continues to drink intermittently during her pregnancy, is motivated to achieve long-term abstinence, but she has not discussed her alcohol use with her OB/GYN yet. So what would be the most reasonable medication option for this patient? I did this talk the other day for some students. This is a trick question. Okay, there are no medications for alcohol use disorder recommended during pregnancy. Again, largely due to the lack of available safety data. So you can consider it initiating some sort of medication after they consult with their OB team. I have seen some individuals where sort of the benefits outweigh the risks, but I've seen some patients on like gabapentin later term in pregnancy. But again, from my standpoint, I always want to make sure that the OB is sort of running point on that and recommending what things would be best. All right, number 5 here, multiple choice question. So patients with severe alcohol use disorder initiated on naltrexone several weeks ago after completing inpatient detox. So again, not the Sinclair method, just the naltrexone daily. Continues to complain of cravings for alcohol. Last alcohol use was prior to detox. Patient is otherwise healthy with no medical contraindications. So which of the following is the most appropriate next steps in the management of this patient? So first, we could try increasing the oral naltrexone. We could try initiating Vivitrol, so the IM injection of the medication. We could also consider adding a camprosate to the naltrexone, adding topiramate to the naltrexone, or also adding the gabapentin to the naltrexone. I never really liked these multiple choice questions when I was doing my testing. But the answer to this one is essentially like, hey, all of these options are actually pretty reasonable for something to try for this patient. Generally speaking, we would probably try to maximize the naltrexone therapy. So you can increase that dose of medication up to 100 milligrams a day, where you can also transition from the oral naltrexone to the Vivitrol, which does have a little bit of data on better efficacy compared to the oral medications. Patients seem to get a little bit better benefit from the IM injection of the medication. So again, all of these are good options, but that would maybe be what we start with. All right, I'll spend just a few minutes here sort of going through an actual patient case, and then we can open the floor up to any questions about sort of alcohol use. But this is a patient that I treated a while back. So 36-year-old male, 20-year history of alcohol use that started in his teens. So he does have a history of both DTs and multiple seizures when he stopped drinking in the past. Again, we always want to confirm with the patient that they've had true delirium tremors where they've actually been hospitalized and not just when they stop drinking, they get this sort of tremor in their hand. Okay. So he's had true DTs, multiple seizures. Last seizure was about a year ago. He says he's currently drinking about a fifth of whiskey per day, somewhere around 750 mLs. He's been in inpatient detox in the past, but has not sustained abstinence for more than a couple of months. So most recent detox was about a year ago. When you see him in the clinic, his blood pressure looks okay, 120 over 80, heart rate's a little elevated, oxygen looks normal. His BAC is 0.265. So again, just a reminder, the legal limit is 0.08. So he's almost 3 times, a little over 3 times the legal limit. But when you talk to this patient, he's alert and oriented. Significant other is with him during the visit, no current medications or allergies, and no significant really medical history. So the question for here is just like, hey, what's the next sort of step in the medication management for this individual? And so, first of all, anytime you have a patient with that high of a breathalyzer test, we want to make sure the patient didn't drive to the clinic, or we don't want to let him leave without notifying the police, right? So he did not drive and his significant others with him. We want to first diagnose him with alcohol use disorder based on his history. Again, that's not really a difficult thing based on the story you just heard. This patient obviously has an alcohol use disorder diagnosis. And then we want to talk to the patient's goals. We always talked about this. Hey, is the goal to really stop alcohol all at once, or is it to cut back and control his alcohol use? So he does want to sort of cut back his drinking and control it, but his long-term goal is to stop. But he doesn't really think that he can accomplish that goal based on his history. So for an individual like this, again, the highest, safest recommendations is that we recommend this patient go to detox or go to the emergency room. That's the safest thing for him. I'm going to document that. But he's refusing to go to the ER. He doesn't get treated well. He's done that multiple times in the past. So I did discuss with this patient starting the Sinclair method, and we talked about just the goal for him of reducing his drinking over the course of the next 4 to 6 months. So the goal is that he's going to reduce his drinking over 4 to 6 months, and then at that point he's going to be able to hopefully make a decision: can I stop drinking fully, or do I want to continue to drink at some sort of healthy level? Reiterated to this patient, hey, if you decide to stop drinking at any time, you need to go to the ER, you need to go to detox. So initially, when I see this patient, he does not have any signs of liver failure noted on the physical exam. We talked about that, of initiating naltrexone on individuals. As long as they don't have a physical sign of liver failure, you can go ahead and start them on the medication. But we did order blood work So that was sort of the initial visit. So he comes into a second appointment. It's about a week later. He did start the naltrexone, and he did not feel like drinking after he started the naltrexone. He actually stopped drinking for 2 days. So his significant other was with him the whole time, said he started having severe withdrawals. She reports that he had a seizure. However, she did not take him to the ER, did not call 911, gave him a few drinks, and he did start to feel a little bit better. So currently drinking a week later about half a liter, 500 mLs of whiskey. His last drink was last night. He has not continued to take the naltrexone because it made him kind of feel funny and a little bit nauseated. So you can see his vital signs here on the second visit. Heart rate is elevated, blood pressure is elevated, oxygen is normal, but his breathalyzer test is negative. So no chest pain, shortness of breath. So what are the next steps for this individual on the second visit? So again, similar to the first visit, I want to reiterate, hey, my highest recommendation for you is that you go to the ER or go to detox, and patient is refusing to do that again. Review the Sinclair method with him. And not surprisingly to me, but he did not really remember much of our initial conversation about the Sinclair method. Thankfully, he had a significant other that was with him that remembered most of the conversation. But I just say that to point out, hey, when patients' breathalyzer tests are 2 to 3 to 4 times the legal limit, I guess I don't really see 4, but 2 to 3 times, I will often have a conversation with them that they will not remember much of, even though I feel like we're having a very lucid conversation during our interaction together. So we talked about that. We decided to decrease the naltrexone dose, so 25 milligrams instead of 50 an hour before dosing. And sometimes you can even recommend this for the first week due to side effects. And then I'm going to have the patient return to the clinic in 2 days. So he comes back a couple days later. He is feeling a little bit better, taking the naltrexone prior to dosing, drinking the same. Last drink was at 10 o'clock last night. We did draw some bloods, but blood work this on his third appointment. But you can see vital signs look better, heart rate looks good, BAC is negative. So third appointment, he's actually doing a little bit better. The fourth appointment, he comes in. So this is like, another week later. So we get his blood work back, but essentially he's tolerating the 25 milligram naltrexone. Okay. He's down to drinking 1 time a day, which actually is a significant improvement for this individual. He does say that he's actually able to sleep at night. Again, he's not having any physical signs of liver failure. And then again, when I go over that with the individual, I just say, hey, make sure you're not having an abdominal pain, nausea, vomiting, fever, dark stools, or jaundice. Blood pressure, vital signs look about the same as last time. His BAC is negative, but I did include sort of his LFT results on the chart here. So again, his GGT is bad, but we would expect his liver function test to look pretty lousy. AST, ALT, ALP, everything is elevated. His bilirubin is like super high, so that does raise some concerns for me. It's like a 4. So I did talk to my medical director about this patient at this point in the conversation and just said, hey, what do we do with him? Do we continue to prescribe him naltrexone or do we kind of hold off? And sort of the recommendation was, hey, let's educate the individual about what we're doing. Make sure he's aware of the risks, right? If he's not having any physical signs, he can continue the treatment. We'll recheck his liver function in a couple of months. And so had that conversation with the individual. He wanted to continue the naltrexone. We did go ahead and keep him at the 25 milligrams at this point, and we ended up seeing him back in a week or so. So here's his blood work from 2 months later. And so again, although it's not perfect, you can see a significant decrease in the GGT, down to 763. The AST actually is a little bit worse, as well as the ALP, but the bilirubin is significantly improved, back down to 0.8. So again, this patient is still in progress. He's been coming relatively consistently to his appointments. And I just want to throw in there too, hey, the goal here is like we would get to a patient before he gets to this place, right? We want to like have early intervention to try to help patients with sort of a Sinclair method or some sort of treatment. But again, having this as an option for him, and anytime we see an individual, we can always change the plan at any time, right? So we can do this for a while, and if he says nope, actually do want to be totally done with alcohol use. All right, great. Let's go to detox, find a way to get him off of the alcohol, and then we can either continue the naltrexone or add some of the other medications. So that is all I have for you guys. So I'll stop sharing my screen and we'll see if there's any questions or things in the chat.
Yeah. Got a few things in the chat, and Gail provided a couple answers there. I'll just go through those in case people missed that. So Richard asked, why is topiramate contraindicated in pregnancy? And then Gail, and I think you touched on this, and Gail said topiramate, there's a risk of tetragenicity. Risks include low birth weight, based on human data and oral clefts. So I don't know anything else related to topiramate and pregnancy.
No, I think that makes sense. It's just one of those things from my standpoint is like whenever I'm dealing with a pregnant female, if there's any concerns with the medications, I just want to make sure that the OB team is signing off on that. So yeah, I think that's great.
Another question about Vivitrol. What is the retention rate of Vivitrol? The injection is painful.
Yeah, that's a really good question. One of my frustrations with treating alcohol patient use disorders or patients with alcohol use disorder is just the retention is always difficult. So the oral medication is a little bit easier to take, but the other side of it too is like patients sometimes like just getting an injection and not thinking about it. So yes, the injection site is painful, but I would say not super painful. You sort of alternate the sites every other time. I say not super painful because we give Sublocade to our individuals, and that one like really hurts. Patients really don't like getting Sublocade. So compared to that, Vivitrol is great. I've seen patients on Vivitrol for 6 months, sometimes 12 months, but I would say that generally patients are going to stay on this medication, in my experience, maybe 3 to 6 months. And then eventually I just stop seeing them. So I don't know if that means if there's a return to use in that individual, or if they just have gotten to a point where they don't need to continue it, or if they're just getting it from their primary care doctor and not coming to see me every single month in the clinic or something like that. So I would just say that patients do pretty well on it. I don't know like specific numbers on the rates, but the shot is a little bit painful, which is obviously great. We can do the oral medication if we need to, but yeah, patients will tolerate the injection. Okay.
And I just want to add on to that regarding the retention rate. It's significantly higher for Vivitrol than it is for the oral medication. It works a heck of a lot better. So commonly in the hospital systems, when we want to start a patient on it, we'll generally do like 2 days of the oral form and immediately get them over to Vivitrol because the efficacy is so much higher. Retention, if I am going based off memory, but it's about 60%. And I don't know if it was 2 months or 3 months, but I mean, it was across. A lot of the studies do look at a year, and they do find that oral form, patients will just stop taking it because it sucks to take pills. It's easy to stop them. Can't stop the monthly injectable because it's already in your system. And then if a stressor happens, well, maybe during that period they would have stopped the oral form, but the stressor's now gone. So when the month comes back around, then they go to their appointment. As long as that appointment is already set up for them, they generally will come. So yes, I'm a huge advocate getting them over to Vivitrol.
Great input. Thanks, Steph.
Let's see, a couple more things on alcohol, then we'll go back. There's one on cannabis too. Todd put a link from the FDA in the chat about topiramate and risk of birth defects, so you can see some more information there. I think we have one more question right now on alcohol. What was your reason for waiting so long on the blood work for the heavy drinker?
Yeah, that's a great question. So in the perfect world, I would have probably liked to draw that blood work a month later. The reality of the current system that I work in and the patient getting there, if they come late, I can't get it drawn at a certain time. So this just ended up sort of being, because the patient was showing up late to his appointments, we had to get him there early enough in the day to draw it. So yes, in a perfect world, I would probably recheck that at a month, but it ended up being 2 months later by the time we had got the blood work done. So good question.
And then we had one about cannabis. Clint asked, is gabapentin first line for cannabis use disorder? Gail did give an answer. Gail said there are no common medications approved for cannabis withdrawal syndrome. There are options that may have some benefit and are considered off-label. So just wanted to read that. I don't know if there's any other comments related to gabapentin and cannabis use from our panelists. Next question, another one on cannabis that just came in. How common is cannabis withdrawal syndrome, and why do some get it and many do not?
There is some people are more prone to it just genetically, and that's why they do experience compared to others. Um,
And
And
I just want, oh, sorry, keep going. I didn't mean to
go
interrupt.
ahead. No, go ahead.
So how common is it? I mean, it depends on how much you're using. If you're only using once a week, obviously you're not going to get it. So if you're comparing people that are all using it consistently for weeks on end, it's going to be 100% prevalence in all of those individuals. And then as Gail just mentioned, genetics certainly plays a part in how severe those symptoms will be, but all of them will have some severity of symptoms of withdrawal when they use it consistently. And yeah, that comes down to genetics. But even some of the symptoms, like people won't even notice it. Maybe they're having like a mood swing and that would actually be attributed to that, but we kind of put it off as something else. Oh, hormones. Oh, they had a bad day at work. So it really just varies.
I'm not seeing any other questions at the moment, but please feel free to keep those coming. Stephanie, do you want to cover some case studies related to methamphetamine?
Yes, I do. And it's really one case study, but it's like, I really don't need to add more because everybody's going to know this case study. Okay, why can't I share it? Oh, there it is. Okay, so I'm wanting to do a specific case that I'm sure everybody here has either seen in their practice, heard about it from somebody else, or have a friend, or somewhere in the population has this been a story that you've heard or have been a part of in some way, shape, or form. And it's ADHD and substance use. I'm going to talk more about stimulant use because the case that I'm going to present is relevant in this case, and it's relevant to ADHD, but it's really all substance use. And it's the textbook scenario that, especially those in primary care, of what you guys see coming into the office and the things that they ask. And let's go right in. So the one thing I wanted to start right away is I wanted to say, do we treat? Because a lot of times we'll say, do we treat or not? Do we not treat? And the and part should never be on that question. It should be, do we treat? Yes, we treat. We treat ADHD, we treat substance use. No one diagnosis gets to be put off the side for another. So I just want to preface that right away. Okay, so I just wanted to put in a couple just review facts from some of my other lectures regarding ADHD. If you guys have ever been in my other lectures, this is an area I'm extremely passionate about, as it's commonly found in the symptoms, before people develop substance use or get into substances. You can generally, a lot of those individuals, you can find ADHD symptoms. So 60% of child ADHD symptoms progress into adulthood. And when I say 60%, I'm not actually meaning 60% of child cases. I'm saying we witness and can visualize 60% of those individuals will have observable symptoms in adulthood. That does not mean the other 40% are ADHD free. Once you are diagnosed with ADHD, whether in childhood, that diagnosis continues in adults. So we used to think that this was a childhood diagnosis, and it's certainly not. We've kind of put on the expectations on adults that they got to figure it out. And the ones that don't, we let the criminal system handle that. And the ones that do, we reward them as they go home and struggle and they have a hoarding type house, but really it's they can't tolerate adulthood without the treatment of their ADHD. In the US, the prevalence of adult ADHD is roughly 2 to 5%, and this is similar to children. So we're actually seeing the consistency that they have it as a kid, they have it as an adult, and I don't think that's really hard to comprehend for anybody. 120 million days of annual work lost are attributed to those for people with ADHD that are not receiving treatment, and that's about $19.5 billion that are lost because of this. Not a lot of studies, when they look at the prevalence associated with whatever mental disorder, compare it to substance use. A lot of them actually leave ADHD out. A lot of them, ADHD is commonly left out because it's like the taboo diagnosis that nobody really wants to have involved in their treatment plan, because of the fact that its number one treatment, of course, is a stimulant. But in that study, one of the recent study, they did find adult ADHD to be 4.4%. So that's consistent with what some of the other reports are estimating. With regards to the rate of co-occurrence of ADHD and substance use, it found that 15.2% of individuals with adult ADHD met diagnostic criteria of some substance use disorder as compared to 5.6. So, when you look at those numbers, 15% to 5%, is it that big? And yeah, it's huge. Anybody with a little bit of background in research or not in research, whether you just enjoy reading it, can know that that's a significant difference despite it only being 10%. And this goes to show how many of the adults in the United States are affected by this. And as I mentioned before, ADHD often misdiagnosed and mistreated in adults because it's often thought of as a childhood problem. And this, if there's one thing that I wish I could eliminate from our views of ADHD, I don't know how it ever started. Probably that and drug holidays. It's the fact that it's associated with children. It is not. It's in adults. They are struggling. So we got to treat it. So the case that I'm going to present, and any questions associated with any, you guys can bring up questions associated with cases that you've seen. It'll all be kind of similar, but I wanted to start with this and then we can build on it. So I'll start at the top, the medication. So this 37-year-old male came to me, first time visit, wanted to get established. And when he was making the appointment, he said, "Oh yeah, I also want to be tested for ADHD." And so he said, "Oh yeah." The medications he came to me on are Xanax, 1 milligram, consistently taking it, of course, Cymbalta, he was on Seroquel, and he was on Zoloft. So an interesting combination of medications, but certainly not out of the norm for anything I've ever seen. So just some background about him. He's, as I mentioned, 37-year-old. He's got a history of substance use, significant history, and he's got no other psychiatric diagnoses. When he came in, one of the first things he said is, "I tried a friend Adderall once and it really helped. It was like night and day difference for me." Some more information about him. He is a veteran. He did 3 tours, all combat. He describes his time in those combat zones as the best time of his life. He often, a lot of times as it came out and he got more comfortable talking about it, he thought he was a sociopath because he loved war. He loved being in that scenario. He excelled in the military, got many awards until he was transferred to a desk job, Within 1 year of that job, he was diagnosed as alcohol use disorder. He ended up getting 3 DUIs. Military said goodbye, and they discharged him, gave him a general discharge. Within a short time after that, the substance use ramped up. Dabbled in, as he said, everything, but the longest use was alcohol. It was readily available, especially in the military. It wasn't looked down upon as much as other substances are. A statement that he and many people with ADHD will often say is, "I can stop anytime I want." And we hear it, maybe roll our eyes and say, yeah, I've heard that before. There is some truth to that with people with ADHD, if it's not the substance that's actually treating their ADHD. After about 4 years after his military discharge, he had his first exposure to methamphetamine. By the 3rd time he used, he was already using IV. And then subsequently, I think it was like 2 months after that, he had a prison incarceration. He was sentenced for 8 years, which was pretty extensive, given that he had no other history. He did have access to methamphetamine in prison. So he really didn't have any clear substance-free period by the time he came to my office. I think he had been out of prison, like, I want to say it was like not even a full 2 months at that point. So, you know, kind of a short window. But he was being proactive and trying to get this established because somebody at one point told him, hey, you should get evaluated for ADHD. You sound like you have ADHD. And then he thought back to the time he tried Adderall. So the big question, I think I have ADHD. Can you prescribe me Adderall? So I'm going to first open it up. I'm going to see how much time do we have? Sorry, guys. Okay, we have a little bit of time. Before I get into this, I want to ask you guys, what are your thoughts on this? I mean, this sentence right here, knowing his history, I mean, this is kind of a triggering response for anybody in medicine. It makes you kind of shut down, dread it. I don't even want to talk to this person. Some people immediately go, they're just trying to have me give them meth. I'm not going to give them, you know, the means to their substance use disorder. Some people, like, I have absolutely no idea what to do. I'm not comfortable with this. I don't even want to touch this. So what are some things that you guys have thought with when it comes to this type of patient? Feel free to, and you can put in the chat too. I don't know if I can see it though. Okay, if anybody has anything in the chat, can one of the experts read it? For some
Yeah,
reason,
I'll keep an eye on the chat. I don't see anything in the chat yet.
And that's fine if you guys don't want to, if you don't want to talk about any of the experiences with it, you know, you certainly don't have to. And the reason why I bring this up is because I know anybody in medicine has in some way had this patient, and it generally doesn't produce a good reaction. Nobody, you know, is like, yes, this is my favorite patient. I mean, I say that, but I'm weird. And this, I love this patient. I love this class of patients because you can do so much good for them, and it can have such an impact on their life. So my question would be, do we treat it? Yes, we are, you know, as I mentioned before, we always treat it. Now, do we treat concurrently? Do we treat one over the other? Which one goes first and which one goes second? None of them go first and none of them go second. We can't expect a certain amount of time of substance free, and if they do that, we reward them with a treatment for their ADHD. That's unrealistic and that's not fair. And they will fail every time if that's the expectation. So we got to treat both. Going back to his medications, the problem that I have with some of them and why I didn't want to start a stimulant immediately off the bat is because he had the Xanax on there and the Seroquel. These are going to be two medications that are directly going against the stimulant. And so, I mean, I'm just setting him up for failure or for increasing his dose or taking, you know, a 30-day supply within a week, trying to get the effect that he needs to feel like a normal person in society. So the best thing for him is we had to come off of that. And he had been on Xanax throughout his life. I mean, you know, he not in prison, but a good majority of his life pre, and he immediately went back on it when he came to me. And Xanax was the thing. It was a thing that was his crutch. It was whenever he felt anxious, this is what he would go to. In the few months that I did prescribe it for him, he was always on time, and he would get extremely aggressive, like the textbook patient, you know, calling for a benzodiazepine refill. But it's not because he was necessarily misusing it. It's because the withdrawal effects suck and they're miserable. And that's what he was trying to avoid. So that aggressiveness is related to that. So I presented the scenario to him. I said, let's come off Xanax. I want to put you on a stimulant. You absolutely do have ADHD, but we got to get you off these medications if it's going to have any effects. He said, okay. I did a pretty aggressive taper, got him off Xanax. I got him off the Seroquel as well. I just stopped that. I actually took him off the Zoloft all at the same time. I left the Cymbalta for the time being while I started the stimulant, but I also, with the plan, within a couple weeks, I also cross tapered as well. Within 3 months, he was on a great dose of Vyvanse. We tried Concerta before that, ended up not working well for him, so he went right to Vyvanse, and he did exceptionally well. I saw him for a couple years, and the last time I saw him, he described it as the feeling he would get when he was in war. And this is a common thing, especially with the veteran population. The military, I'm going to give you a little bit of background information real quick, but the military back in the day had these questionnaires and how they would screen men for coming into the military, and they would look for this certain personality or this certain diagnostic criterion. Maybe they did or didn't know at the time, but they were essentially looking for ADHD. I believe they did know, because they have little programs now that are gearing towards ADHD, so they're almost trying to fix the errors that they ended up causing because of this. But that's a whole different story. Anyway, so they were looking for the ADHD person, and they would come into the military and they would excel, because these combat zones, they're a treatment. It was self-treating in a war, in a scary, life-threatening zone. His dopamine was rising, and so that's generally why he did so well under stress when other people didn't. And so that's consistently getting award after award until that he was transferred to the desk job. People with ADHD have to have that stimulation if they're not being treated, and without it, they get really, really depressed, and that's when the substance use comes into play here. So with him, a couple years go by, we treated him, and he had a significant methamphetamine use. I mean, and it was IV use. He had some chronic conditions as a result of that. And with the successful treatment of the ADHD, he did not relapse on methamphetamine once, which is consistent in the literature. It's consistent in the research. It doesn't increase the risk of relapse, and it doesn't increase the risk that they will misuse their stimulant. They always wanted to feel different. They wanted to feel normal. They wanted to feel like they can function in society, and unfortunately, the substance that they find ultimately does that. But once they're able to find a medication that doesn't cause all the negative things, it's not illegal, they will not misuse it, and they will generally do quite well on it, even with that substance use history. So with all that being said, what questions do you guys have? I know we only have a little bit of time, so I want to make sure that you guys are able to ask questions, because I know this is not atypical for the patients that you have all seen as well.
So we had a couple comments in the chat related to this patient. Maybe for now, I'll skip over those. You can see those in the chat. We had a couple questions that looks like related to your talk here. We'll go to this one first. What about a slow reduction of alprazolam for this patient you just mentioned here?
I certainly could do a slow reduction, but it wasn't necessary. He was motivated to come off of it. I was motivated for him to come off of it, because ultimately it was making the anxiety worse, and it's gonna prevent the full effect of his stimulant. So in a case like this, would there be a scenario where I would do a slow reduction? Sure, there's always a scenario. But if I don't have to, I absolutely won't, because it's gonna help the patient the most the sooner they can get off the Xanax. And they're not gonna get anxious. Once that stimulant is on board, it's actually gonna be the treatment for their anxiety, much better than Xanax could ever treat. So it's a good thing to get them off as quick as possible.
Let's see here. We had a comment about feeling uncomfortable with Adderall. They would lean to a non-stimulant for this patient. Any comments on that?
I would never lean towards a non-stimulant, because this is, we're bringing the substance use history as a decider of our treatment. And the research is consistent. A stimulant is the #1 approved medication for ADHD. And what the research has shown is that when we undertreat ADHD, with substance use and without, but especially in somebody with a substance use history, when we undertreat it, it's more dangerous than not treating. So we never want to set up a scenario where we're kind of withholding treatment because of the fear that we're going to further exacerbate their substance use or they're going to go sell their stimulant. If you got the diagnosis correct, someone with ADHD will never sell their stimulant. They're always going to take it, and it's not going to set them up for misuse of their own stimulant. And I wanted to put in here real quick, just so you guys, just to kind of remind here, ADHD, remember, is a clinical diagnosis. We don't need to send patients off for thousands of dollars worth of psychological testing. Please don't do that. You know, it's putting a barrier for people getting the treatment of ADHD, and it's not helpful. It can detect a small set of a certain type. You know, there's not really a type, but a certain type of ADHD. But for the other ones, they're either going to score exceptionally well on those tests, and it's going to say they absolutely don't have ADHD when they do, or they're going to score exceptionally low. There's no in between there. So half of them are not even going to be, they're not going to even screen positive for ADHD. So clinical diagnosis, use scales. These are great scales for discovering if somebody has ADHD. And people say, well, they printed them off. They already memorized the form. You're right. They absolutely do that. Whenever I give out any form, I always cut off the top of it so they don't read what it's for. And that kind of changes the memory. But when you have the conversation with them, you'll figure out quite quickly on whether or not the answers are genuine.
Let's see, we've got a few questions I see in the chat. We'll try to get to those real quick here. Let's see, a quick one. Is ADHD seen more often after alcohol use in pregnancy? Any known causes of ADHD?
Is it seen more often in alcohol use after pregnancy? It is commonly there is a prevalence in detecting ADHD after women have never received treatment, never received a diagnosis after their first pregnancy. That is common for them to seek out assistance, and not necessarily ADHD. They don't know what's wrong, but a lot of times that child causes such disruptions in their patterns, the things that have been getting them by up to this point without failing, and suddenly a child in the mix that they can't kind of have some prediction over. I mean, it disrupts everything, and they kind of lose control and don't know how to function. So that's common after pregnancy. Now, is the question with alcohol with pregnancy?
So I think the
or
question is, sorry,
separate
does
question?
alcohol use during pregnancy cause ADHD in the child?
Okay, so any substance use, I see what you're saying. Any substance use during pregnancy is associated with a risk of increasing the risk of ADHD in children. But the most associated factor is absolutely genetics. If you ever think one of your patients have ADHD, ask them to bring in a parent. Ask them to bring in both parents. One of them, likely both of them, will also have it. ADHD generally pairs with other ADHD individuals because if they pair with non-ADHD individuals, it often leads in divorce because one party gets bored and the other one can't handle the little quirks, and that leads to divorce. But people with ADHD generally find each other either as friendship or as a relationship.
Let's see. Okay, two questions here. Did the patient continue on the sertraline?
No.
No. Yeah.
So they actually didn't have any they didn't meet criteria for major depressive disorder. They didn't meet criteria for generalized anxiety disorder. Their only diagnosis, not related to substances, but their only other diagnosis was ADHD. So there's really no need to increase the serotonin. There's really no need to increase anything other than the thing that they're deficient in, which is dopamine. ADHD is the deficiency across the board in dopamine. So that's the only treatment they needed, and they did very, very well.
So I think that leads to your next question. Was the patient completely off all other medications?
Mhm.
Yes. All right.
And the
Well,
last thing I wanted to mention in a hospital setting, you know, when patients are coming in with withdrawal, and it's pretty brutal, the brain zaps, things like that, the anxiety, the sleepiness, the eating everything in sight. Some off-label medications. I mean, you can certainly use stimulants that'll treat the withdrawal. But then you got to figure out what you're going to do after that. But modafinil is one that's the research is quite positive, and I do use it off label a lot of times because I know it'll actually treat the withdrawal side effects, that and with clonidine. And I also use those off label all the time in ADHD. So it kind of shows the common mechanism of action between those, because modafinil works on the dopamine transporters. So it's the last little tidbit I wanted to add in there.
thank you. We had one question come in. If folks need to hop off now, go ahead. I'll just say there's a link in the chat to the valuation survey. I'll be following up with an email later today. To get that a link to the evaluation survey to get your certificate. So keep an eye out for that email. This is our last training in this current cycle, so we'll be taking a month off and we'll be back in October. So if you need to hop off now, I can read this question if our panelists have time to stick around for an extra minute. The question is, how do we get a good way to test and confirm diagnosis of adult ADHD? And it seems everyone feels they have it now. It seems like psych is very booked out for testing. Thanks for the discussion.
Yeah, and that's true. And unfortunately, there's even stigma associated within the psychiatry community. I have heard psychiatrists say, "Well, you know, I don't believe in that." Well, you can't really not believe in it because it's a real thing. But going back to those scales, that's the best way to do it. And in providing the scales, providing multiple scales, because a lot of times if patients are just kind of come in and maybe they don't have ADHD, just want the stimulant to maybe go sell it, that would be a true non-ADHD case. They're going to memorize it. They're going to score off the chart in every single one. They're not going to kind of think about it and spread out the answers. You're going to see the pattern. But if you feel like they memorize that one, then there's 5 other ones we can do. Give them all at once and see how they handle it. Generally, they won't and they'll leave. That's too hard. For somebody with ADHD, they will, as hard as that is, they will go through the work in doing everything, every single scale you want, so that they can finally feel normal in life. Their approach and their receptivity to it will kind of really guide you and kind of give you the answer that you're looking for.
Thank you. We will end it there. There's a comment in the chat. It says, Stephanie, thank you for championing ADHD assessment, treatment, and cares.
Absolutely.
Yes, thank you. So, like I said, keep an eye out for some information from me in maybe 2 or 3 weeks about our next series, starting in October. Thanks to everybody for joining us today. And Echo Team, if you have time, we can hop over to that other link for a quick meeting. Thanks.